I'm going to talk a little bit about the value that you add as a neurosurgeon. This is my disclosure. This is our crew kind of at Atrium Center of Excellence. When we look at surgeon collaboration with hospitals, it really is something that is a necessity for both the surgeon and for the hospital system. For as self-assured as a room full of neurosurgeons, spine surgeons, orthopedic spine surgeons have a tendency to be, some people would say not just self-assured, but arrogant. They constantly underestimate their worth to, I think, society, but certainly to the healthcare system in general. Some of that worth is subjective. Hospitals need motivated surgeons to run efficiently. They just do. Is something that's very objective. A busy spine surgeon or a busy neurosurgeon makes a minimum of $3 to $5 million a year in revenues for the hospital system. That's a minimum. Some would argue more like $6 to $8 million a year. So there is a tremendous subjective and objective worth that the surgeon brings to the table that really needs to be recognized. Now, one of the problems is there are challenges, and unfortunately, these challenges have become more apparent in recent times. And you don't have to understand calculus or have a Harvard business degree to understand that when expenses go up and reimbursements go down, that you're going to have a problem. And it just takes a couple of years of high inflation and 5 and 10% inflation, 5 and 10% cuts in your reimbursement for a surgeon to take a gut punch and their practice to take a gut punch. And in Eric's excellent talk earlier this morning, he talked about how the number of physicians who were employed by the hospital had gone all the way down to about 40% of private practice, 60% employed. That's even more pronounced for surgeons. Surgeons are about 75, neurosurgeons specifically are about 75 to 80% hospital employed. And this comes from some of the statistics that we're seeing here. There are financial pressures that are driven spine surgeons, neuro and ortho into the hospital system because the cost of running a practice is so high nowadays with all the administrative burdens that are put on us, EMR, outcomes, et cetera. And again, with this milieu, it is just something that can't be weathered. But we still have a tremendous amount of value, and that's some of the things that I want to talk about where surgeons uniquely can leverage that value. One is ambulatory surgery center. Ambulatory surgery is at the very crest of where it is going to be. There is a tremendous amount of spine surgery that is currently done in the hospital that does not need to be done there. Virtually every ACDF, obviously with exception for patients with medical comorbidities, lumbar discectomies, decompressions, cervical discectomy decompressions, and even now lumbar fusions can be done in the ambulatory center. But for ambulatory center to function properly, they need surgeon input. They need surgeons to be willing to take their patients there. They need surgeons willing to adopt their practices there. But all these things can be gained from a partnership with surgeons and hospitals in ambulatory surgery center. Partnership, marketing, efficiency, patient satisfaction, and it meets a market trend that is ever growing. And this is just going to become more obvious as time goes on. So again, there is a value for physician buy-in. If the surgeon doesn't take his patients there, it cannot be done efficiently. Even surgeons who are employed by hospital can have an ownership interest in a surgery center. Private practice surgeons certainly can have that. And our proof of concept is the surgery center that we set up with our hospital system about 18 years ago. And so that is proof of concept that all those things that we talked about have come to pass with the establishment of the ambulatory surgery center. None of that could have happened without a reasonable partnership with the surgeons and the hospital system. So if we look at some of the mature revenues, this is the best investment a spine surgeon or virtually anyone can make in their time, and this is an 18-year investment that we've had with a joint venture surgery center. It is a 50-50 ownership structure. It is a 50-50 board structure, 50-50 split the profit structure. And so it is not just the concept of surgeons being able to take some financial security away from this, but it is the concept that the patients win. This is virtually 99+% patient satisfaction. Patients, especially old patients, go to hospitals to die. They go to ambulatory surgery centers to keep them active, to keep them up and running. So the patients love it. Surgeons love it because there's a huge efficiency there. The healthcare dollar outcomes have been proven, evidence-based, proven to be just as good as inpatient at a 60% cost savings. So the hospital wins, the patient wins, the healthcare system wins, the surgeons win, but only if they're working together. Surgeons need to understand that the hospitals can do this, but they can't on their own, but they can't do it well. We're in a certificate of need state. We couldn't have gotten our surgery center without the hospital partnering with us. It's a matter of establishing that relationship. The ownership that can occur in both in private practice and in hospital employed surgeons. Gain sharing is another great example. Gain sharing is a legal way. The DOJ has probably had 10, 12 advisory opinions that have said gain sharing up to 50-50 split with the hospitals given certain safeguards is absolutely okay. People who are employed physicians say, well, we're employed, the hospital's not going to give us money. Well, they can give you service line reinvestment. They can specifically make your life easier so you don't have to beg for capital and things like that. If you were a non-employed, if you're a private practice physician, they can give you money. That it's a legal thing, but you need to understand your worth in that. Hospital contracting, directorships. Hospitals have come to understand that they cannot run their service lines efficiently. There are a bucket load of service lines associated with spine surgery and with neurosurgery and with orthopedic surgery. There are trauma, pediatrics, there's a chief of department, there's a Neurospine Institute, there is the Spine Center of Excellence, on and on. These are all fair market value reimbursements that are done at arm's length, but it's a way that you're reimbursed for the time. There is an objective fair market value here. Trauma call, if we look at nerves, there are about 2/3 of practices today receive call pay. Why is that 2/3 that are at a level 1 trauma center? And that should be like 100%. And that is slowly increased over time. You're responsible to take care of your own patients on call, but we don't see our own patients on call. We see patients from 150 miles away who are flown in helicopters and sometimes jets way out of our practice area. And so it's not our responsibility to take care of those patients without pay. You should get call pay. There is a fair market value for level 1, level 2, and level 3 call. Bundled payments. Bundling is something that has occurred with orthopedic joints because it is more of a straightforward process, but spine bundles a little more complex, but actually very straightforward if you look at some of the cases that are being done in the ambulatory center, which we've already said is where the future is headed. These are similar patients. They're generally don't have a lot of comorbidities, ACDF, microdisc decompressions. These are all things that can be bundled, but they can only be done so with the surgeon buy-in for that. If the surgeons won't go to the ambulatory center with their patients, and they won't allow the bundle to be efficient unless they're on board with that. So this, again, is this perfect environment that exists for surgeons to understand their worth and take advantage of that. So what we're kind of left with is a spectrum that goes from private practice to hospital employment. Those are our models that exist right now. We've already talked about that there is a huge shift towards that hospital employment. Unfortunately, what comes with that is a lot of loss of a physician autonomy. The people who suffer for that are the patients. Surgeons are the best #1 advocates for the patients. And as they lose their autonomy, their ability to do the right thing for the patient, as they become subservient to somebody else, it's the patient and the healthcare population in general that suffers. So there are other ways there's not private practice and hospital employment. There's PSA agreements, professional service agreements, which are considered to be kind of employment light, where the practice remains an independent contractor, but the hospital takes on a bunch of the burden of administrating the healthcare costs, like we said, have gone up. And that's the traditional kind of PSA model, where the hospital assumes ownership of the practice's administration, but the practice still remains an independent entity. Global payment PSA, carve-out PSA. So there's different ways to kind of crack that nut. But the reality is that the surgeons remain at the center of this. For any of these models to work, hospitals and hospital systems need to have surgeon buy-in. The patient needs to have the surgeon as their advocate. So all these new models should not be intimidating, whether it's a CIN, spine bundle, PSA. These are potentially disruptive, but whenever there is disruption, there is an opportunity for gain, and there is an opportunity for surgeons to keep themselves at the center of the healthcare universe. And in fact, I would argue that it is imperative that surgeons understand their value, leverage it, and maintain that autonomy, and maintain their centricity as the patient's #1 advocate. Thank you for your attention this morning. I appreciate it. Great job, Eric.